it is more than 2 hours, multiples without epidural, it is more than 1 hour, consider as prolonged second stage of labor. So, in summary, indication for forceps deliveries are three folds: fetal, maternal, and any other condition that necessitate to reduce the shorten the second stage of labor. So then fetal is fetal compromise, maternal exhaustion, prolonged second stage of labor. Any maternal condition, what I mentioned here, needling, shortening of the second stage of labor are indications for forceps deliveries. So if a woman on epidural anesthesia, you consider as 3 hours in primate is prolonged second stage, multip is 2 hours on regional anesthesia. Without regional anesthesia, you consider 2 hours and 1 hour, both in the primate 2 hours, multip 1 hour. So this is very important slide. Before applying forceps, so there are 10 prerequisites. So mother has to fulfill these prerequisites to apply forceps. So first of all, before you decide forceps delivery, you have to assess the mother. So you do an abdominal examination, do vaginal examination, and see mother is suitable for forceps delivery. So the RCOG green top, according to the green top guidelines, they categorize these prerequisites as follows. It has to be engaged fully, or 1/5 when you examine the abdomen. So then, if it is one or more than one, so it is risky to apply forceps. Vaginal examination should reveal vertex presentation. Any other presentation, you don't apply forceps. Cervix has to be fully dilated and membrane should be ruptured. So you have to determine exact position of fetal head to place the forceps. Otherwise, what will happen is, without knowing so at the end of the lecture, I will answer this question but posted at the moment. Right. So prerequisite, head has to be fully engaged or one less than or equal 1/5 abdominally. Vaginal examination, there should be a vertex presentation. Cervix has to be fully dilated. And membrane should. Do you have any questions? Any questions up to now? Okay. So then exact position has to be determined for the proper placement of the instrument. Otherwise, what will happen is, if you don't know whether it is right occipital anterior, left occipital posterior, whether it is transverse, so otherwise what happens is you apply the forceps without knowing the position. So it may be across the because of that, so you need to determine the exact position of the fetal head. There should not be significant caput and molding. Significant caput and molding indicate features of obstruction. So if there are features of obstruction, it is a contraindication for forceps delivery. It is a contraindication. Then pelvis deemed to be adequate. It should not be contracted pelvis. So if there is a contracted pelvis, so that it implies the maternal pelvis is not adequate for the vaginal delivery. So you should not apply forceps. So other prerequisites, like you have to get the consent, verbal consent, need maternal cooperation, need good analgesia. Most of the situation, so we use bilateral pudendal block and perineal infiltration. Mother should have contractions. So those are the prerequisites for the operative vaginal deliveries. So you have to remember these prerequisites. There are 10 prerequisites. Before applying forceps, you have to see whether these things are fulfilled. I forgot to tell other one is bladder should be empty. Bladder should be empty. How to prepare mother for delivery? You have to explain the mother and get informed consent. You need to use appropriate analgesia. So pudendal block, as I said, may be adequate. Maternal bladder has to be empty, otherwise what happens is you can damage the bladder and it may not be descent. It has to be aseptic technique. You can use antibiotics within first 24 hours. So this is how you should prepare the mother for forceps delivery. So at the same time, operator, doctor should know with their knowledge, experience and skills of necessary. And adequate facilities should be available. Equipment, bed, lighting. So there should be a backup plan in case of failure to deliver, especially when you conduct in mid-cavity deliveries. That's mean in failing, so you have to convert it to cesarean section. So that is called trial of forceps delivery. It has to be done in the theater. In case of failure, you have to convert to the forceps delivery to the abdominal delivery. So senior obstetrician competent in performing mid-cavity delivery should be present if a junior trainee is performing the delivery. Otherwise, every forceps delivery should be informed the consultant. So you have to anticipate complications that may arise. For example, so there is a high chance they to develop shoulder dystocia and postpartum hemorrhage due to trauma. So you have to have backup facilities to manage this kind of problems. And at the same time, neonatology team should be available at the time of forceps delivery. If there is any case, people birth asphyxia, they need resuscitation. So you understand now, so what are the requirements? Experienced obstetrician, backup facilities for cesarean section, consent, good analgesia, theatre facilities, antibiotics, anticipating complications, informing the consultant. Those are very important steps in vaginal delivery, so operative vaginal deliveries. So these details are not that important for you. Just for the interest, I put down these pictures, how to apply the forceps. First, what you need to know is, if you apply forceps, the first should be the blade that is to the maternal left. First blade has to be, the insertion blade has to be maternal left. Then apply this way, and then so you assemble and then traction. So what you have to remember, it has to be gentle traction, intermittent, horizontal direction. So you should not apply excessive traction because if the baby is easily deliverable, with the intermittent gentle traction they may deliver. So if you want to apply extensive pressure, power, means there is some problem. It may be a relative obstruction or absolutely obstruction. So with the presence of the obstruction, if you are going to deliver the baby, there is a damage to baby as well as the damage to mother. So episiotomy is not compulsory, but it is a good practice to put up episiotomy, but you have to remember it is not a compulsory requirement. Those are the axial tractions applied. Which means you can see first of all you have to apply the pressure, the power downwards, and then gradually when the baby's head is delivering, you have to go up in the semicircle manner. So when the baby head is delivering, so there is a levering effect over the symphysis pubis, and then you have to go perpendicular to the floor at the time of fetal head delivery. So you can apply forceps in different situations. Occipito-anterior head, occipito-anterior position, you can apply. Slight deviation less than 45, you can apply. Direct occipito-posterior, you can apply forceps, posterior position, occipito-posterior, but you have to remember occipito-posterior, any rotation, you can't apply forceps. That's mean where you can't apply forceps, any rotation from occipito-posterior or transverse line. Other than that, other situation you can apply forceps. But the contrast is the vacuum, rotational vacuum. You can apply rotational vacuum any position of the fetal head. That difference you have to remember. Any rotation you can apply vacuum, but not forceps. So what are the problems due to forceps deliveries? So rotation is greater. So that's mean the easiest and less damage can happen if the head is direct occipito-anterior posterior. But if there is a slighter deviation of sagittal suture, there may be a greater morbidity and mortality, laceration and blood loss. And at the same time, forceps is associated with the higher perineal episiotomy rates and third and fourth degree laceration of obstetric anal, that is called obstetric anal sphincter injury. Postpartum urinary retention and bladder dysfunctions are higher than other vaginal deliveries. And say anal sphincter dysfunction is much higher in forceps deliveries. Infection, that is why we have to do antibiotics. Pelvic hematoma, traumatic postpartum hemorrhage and shock. So those are some morbidity of forceps delivery. Fetal morbidity, capella hematoma, skull fractures and intracranial hemorrhage. Brain damage, more seriously. Then marked depression of respiration and asphyxia, facial palsy, brachial palsy. At the same time, babies can get soft tissue injuries to face, bruising and laceration, cord compression, convulsions. So those are known complications of forceps deliveries to the baby. So these things mainly happen due to wrong application without knowing the correct position of the fetal head. So at the same time, excessive traction can cause more fetal morbidity. So I talk about trial of forceps. Trial of forceps are, you can do the forceps delivery in the labor room or theatre. Trial of forceps is the forceps delivery you do at theatre. There you have some uncertainty that forceps may fail. In that case, I said go for vaginal, so it's cesarean section. Especially, for example, large babies, maternal obesity, poor contractions. So those are some few examples. Failure can happen. So they are always you do trial of forceps delivery in the theatre rather than in the labor room. Labor room you do the uncomplicated forceps deliveries. There is something called failed forceps deliveries. So how you identify the failed forceps deliveries? So that is very important. You have to identify what time you should abandon the procedure. Otherwise, you apply traction, thinking that they will deliver because people are around. So then if you fail, you think that is shame to you. So you try to deliver maybe whatever this thing. So there what you can do, what happen is more damage. So then genuinely you should know what point you should abandon the procedure. That is called failed forceps delivery. So I mentioned few things. Fetal head does not advance with each pull. Your fetal head is not coming down. With each pull, you should abandon the procedure. Fetus is undelivering after 3 pulls with no descent. If the baby is not delivering with 3 pulls, you should abandon the procedure. If forceps fails, directly go for cesarean. Yeah, this is the documentation. So forceps delivery associated with lot of legal claims around the world. It may be short term, intermediate and long term. You can have brachial plexus injuries, nerve injuries, palsies and damage and asphyxia and the ischemic cerebral encephalopathy. Later on, cerebral palsy, intracranial hemorrhages, maternal sphincter damage, fecal incontinence. Because of that, operative vaginal delivery has a high risk of suing you due to whatever negligence or whatever the things. But it is known that instrument can cause complications, but you have to identify the complication, you have to minimize. But if you follow the procedures, documentation, even though there are complications happen, people can't sue you because forceps are known to cause complications. Nobody can avoid it. So, but intention you haven't done that. So, documentation is very, very important in forceps delivery because you don't know that sometimes some people may sue you, say 5-10 years time. Then you don't know, even you can't remember the incidents happened. But if you document in this way, so it is, you can defend yourself in the court of law. Please, when you come as a house officer, or if you are doing any postgraduate or course or whatever, so you should know how to document this thing. So then you are safe. So these are the few the templates how to document. You have to put the date, operator name, what is the SHO or registrar, what is rate, supervisor, the consultant directly supervise you, indications, classification with the outlet, locality, mid-cavity, rotation, fetal well-being, CTG normal, then examination finding, where the things are done, the labor room theatre, what is analgesia, dilatation, consent, catheterization, molding, caput, procedure, number of pull, traction. So everything is here. So you just need to put a round here, indicate. So then the knot is 100% complete. Then you are safe. So if there's a problem happen, you can say, yes, I know that forceps can cause problems. It is well recognized, but I have done the procedure in the correct way. But this can happen. Sorry, can't help. So then you are safe. You have to follow, and documentation is very, very important in the forceps deliveries. You have to remember. So these are the rest of the aftercare. Blood loss, fetal weight. So what you are going to do later, everything here. So now I'm going to talk about the most of the things I talk are common for the instrumental delivery, but I will talk something about the vacuum extraction, that is called 1-2 delivery. So there are several types of 1-2 delivery. According to the cup is made of metallic. It is metal cup, and sometimes plastic, silicon. So I will give some. I will tell you some questions asked by you. Can we do the forceps delivery if the fetus is in abnormal presentation, like face presentation, ventro anterior? Face presentation, forceps delivery is contraindication. Ventro anterior may deliver vaginally without any problem. Can you please describe the use of forceps and vacuum in different fetal positions? Again, yeah, easy to remember. Vacuum, rotational vacuum, you can use any position of the fetal head. It may be occipital anterior, posterior, transverse, side rotation. But forceps delivery, you can't do forceps delivery right occipital posterior, right occipital lateral, or transverse. Remember those three. In any other position, you can do forceps. Right occipital lateral, so right occipital posterior, left occipital posterior, transverse. How can proliferative retinopathy become an indication for forceps delivery? Because the proliferative retinopathy is a kind of vascular malformation happening there. So if a mother is trying to push the baby, so there is an increased pressure. So then what happens is this retinal vessel can burst, damage, and there may be a lot of bleeding there, retinal detachment, and these things are possible. So at the same time, you mentioned about we cannot hear properly. You can't hear.
Can hear, sir.
Yes, somebody mentioned that you can't hear. Right. So our forceps delivery is contraindicated in bleeding disorders, ITP. Absolutely yes. Because in ITP, baby can have fetal thrombocytopenia due to crossing IgG antibodies. Because it is a kind of immune response, ITP developed due to immune response. Baby can have transplacental IgG transmission. Then what happens is that baby can have fetal thrombocytopenia. So any case of ITP, so it is recommended forceps are contraindicated. Even scalp blood sampling, any intervention to fetus are contraindicated. Right. Now again we go to the lecture. So according to the cuff made up of metallic or plastic, you can say soft cup vacuum extractors, metal cup vacuum extractors, and rotational and non-rotational vacuum. So vacuum, there are two the vacuum deliveries you can do. One thing is rotational there. So vacuum cup is rotating. So that is why it is fitted to any position of fetal head. It mimics. So you have to understand. Force the vacuum delivery mimics natural labor, not like forcing. Then non-rotational, especially when the rigid the handle is there, so that is non-rotational. There you can't do other rotational deliveries. So application. So this thing you have to know very well. There is thing called flexion point. When you apply vacuum, you have to apply vacuum to the flexion point of the fetal head. So when you apply to the flexion point, so then the fetal head will flex very well and then occupy the shortest diameter, smallest diameter in the pelvic outlet, and then delivery is very easy. You should know where is the flexion point located. It is 3 centimeter front of the posterior fontanelle and 6 centimeter behind the anterior fontanelle. So there is the point there. So then that is called flexion point. So the center of the cup should be overlying the flexion point. So you can see here posterior fontanelle and anterior fontanelle. So 3 centimeters front to the posterior fontanelle is the flexion point. When you apply the vacuum cup, so you have to feel the sagittal suture, feel the posterior fontanelle, and then apply. The center should be the so traction and these things are not that important for you. So this is the how you should do that. First downward, then gradually fetal head is coming, so you have to go up. Again, you should know when to abandon the procedure, stop the procedure. So that is very important. As I said in the forceps delivery, fetal head does not advance with each pull. Fetus is undelivered after 3 pulls with no descent or after 30 minutes. Cup slip of head twice at the proper direction of pull with the maximum negative pressure. So if the cup is slipping, so that is due to some obstruction. So then you have to abandon the procedure. Those are 3 indications to stop the procedure. That is called failed vacuum. Right. Now, so we are going to talk about some points about cesarean section. So cesarean section is the delivery of the baby. Now we call cesarean delivery, not the section. Delivery of the baby through abdominal or abdominal uterine incision. So that's a history. I'm not going to talk about this history, how the cesarean section started in ancient time. But these are for the interesting part in the obstetric history. History means not the when you take from the patient. So how the things are evolved from ancient time. So you can see that the cesarean sections started first with a dead mother due to obstruction or something. So they thought, so burying mother and baby, dead baby and mother, the same soul. So they can't release in next birth. So they separated both baby and mother and they buried. So that was the first impression they had to deliver the baby through the heart